California schools safely. I'm Dr. Deneen Gus, Monterey County Superintendent of Schools, and I'm so thankful that the county superintendents from Region 5 are all here today to welcome you and to thank you for all of the hard work you do daily to ensure that every child has access to a high-quality education, even in the most uncertain times. I don't think any of us could have ever imagined that last March, when we closed our school facilities, shifted overnight to distance learning, and the COVID roller coaster ride began, that we, almost a year later, would still be dealing with the ever-changing circumstances and continued uncertainty. I know how hard you have all been working and that you miss being with your students in person. I also know that as educators, we make decisions based on research and science, and we are not health experts. So we are fortunate today to have Dr. Noble, who I will be introducing shortly, here to share what the research is telling the health experts. Before I introduce Dr. Noble, I'd like to ask each of the Region 5 county superintendents to introduce themselves and give you a short welcome. We're so fortunate that we as regional leaders work very collaboratively and share resources for the benefit of all schools, districts, students, and families in our region. With that, I'm going to turn it over to my colleague, Dr. Marianne Dewan, the Santa Clara County Superintendent of Schools. Marianne?
Good afternoon, everyone, and thank you so much, Dr. Gus. It is really a pleasure to welcome all of you here today. I do want to just take a moment to again thank all of the educators for your dedication and your hard work. It's been incredible to watch what you've been able to do and accomplish since we've been dealing with COVID since last March. I know today's session is going to be very informative and give us a lot of information that will help guide the coming months in our shared work together. So again, thank you for making time for being here today, and thank you, Dr. Gus. Next, I'd like to ask our colleague, Crystal Lamonto, San Benito County Office of Education, to also provide a welcome.
Thank you, Dr. Dewan, and I want to thank Dr. Deneen Gus, who's been instrumental in working with Region 5 to be able to have this amazing presentation today that again focuses on science and the facts. And we know both the mental exhaustion that we have all gone through as educators across all of our regions. And so we empathize with that, but are looking forward to safely reopening when we are able to do that. So today is a great step to be able to provide information, and thanking Dr. Noble for being here today as we look at facts and information as we move forward. So I want to welcome all of our San Benito County participants today, and thank you for joining us. And it is also my great pleasure to introduce my additional colleague. And very fortunate, as Region 5, we all work very closely together. So Dr. Faris Sabah.
Thank you so much, Superintendent Lamonto, and thank you to all our colleagues and friends that are joining us today to listen and learn as we continue to kind of embrace the challenge that COVID-19 has given us. You know, when I think about the things that we have done together as a school community, I think about the resilience of our students and of our parents, the resilience of our amazing teachers and staff, and how we've come together in collaboration to learn from each other, to focus on science, to try to put aside the distractions that would make us make decisions that are not in the best interest of our students, and not in the best interest of our staff, and really think about what are the kinds of things that we need to put in place to support our students, whether it's in distance learning, or as we are getting excited to think about how we are going to be continuing to increase in-person services and supporting students not only for their educational and academic achievement, but also their mental health and their well-being. So in collaboration and in appreciation of the resilience of our community, I am so grateful to all of you. And I'd like to turn it back to our Master of Ceremonies, Dr. Gus, who's going to be introducing our amazing keynote speaker, who's somebody that I've been very excited to hear from in the past, and I think is really going to be able to shed more light on the challenges and also the opportunities we have to serve our students. Dr. Gus?
Thank you so much, Dr. Sabah. At this time, it gives me great pleasure to introduce Dr. Jeannie Noble. She is an associate professor of emergency medicine at UCSF and director of COVID response for the UCSF Emergency Department. She has led a large emergency department through times of inadequate PPE and limited access to testing with 0 cases of patient to provider or provider to provider COVID transmissions. Her strategy for COVID response was published in the British medical journal entitled Emergency Department Preparation for COVID-19 Accelerated Care Units. Dr. Noble has advised several Bay Area hospitals on implementation of COVID safety practices. She also works with Bay Area schools, sharing data on safe reopening strategies. Dr. Noble attended graduate school at UC Berkeley and medical school at UCSF. As global health faculty, Dr. Noble regularly teaches other physicians in resource-poor settings in Mexico, Nicaragua, and Peru. She was deployed to the Navajo Nation in Gallup, New Mexico to assist with their first COVID surge in May of 2020. We welcome and thank Dr. Noble for agreeing to join us today to share her knowledge and her expertise and all of her studies about in-person instruction during a pandemic. We also just want to remind all of our participants today that if you have any questions, please feel free to ask them in the Q&A section of the Zoom. And if you are watching on YouTube, feel free to ask your questions in the linked Google form. We'll do our very best to get to as many questions as we can today. And those that we do not answer today, we'll be sure to get those answers to the participants. I also want to let the participants know that we will be recording the presentation for those who were not able to attend today's session. With that, we welcome Dr. Noble.
Thank you so much for that very warm welcome. I really appreciate it. And I greatly value the opportunity to share the science about the safety of school reopening and best practices. I know a lot of us are suffering from information overload. It's really hard to keep up with the latest data. So again, I appreciate the chance to be here and try to synthesize that for you. Let me just pull up my presentation here. Let me go. All right. So reopening schools safely, best practices. So just starting with why did we close our schools? So we're just about on the 1-year anniversary of school closures, as we all know. So back in March of 2020, we closed our schools because we thought the kids would be the primary drivers of COVID. We thought they'd be at risk for severe illness. We thought schools were likely to be super spreaders. We thought school closures would save thousands of lives. Now we know that we were wrong. What we know now in 2021 is that adults are the primary drivers of COVID transmission. Kids are extremely unlikely to have severe COVID disease. To just put that in perspective, there have been 11 deaths from COVID under people under the age of 18 in California. Among the 45,000 people who have died, just 11 have been under the age of 18. And that compares to 16 deaths for that pediatric age group 0 to 18 from the flu in the 2018-2019 flu season. So flu is more deadly to children than COVID is. And just another kind of point of perspective, 225 children under the age of 18 died from suicide in 2017. That remains one of the top causes of death for kids. And then in the right-hand corner there, you see where we really get the high death rates from COVID. So it's, above the age of 50, for 50 to 69-year-olds, the mortality rate or the death rate per case from COVID gets to 0.5%, which is definitely higher than the flu. And then it's really in our oldest population, 70 to 80-year-olds, that we see over 5% of people who have COVID dying from it, which is really driving those numbers. So what do we know about COVID in schools? So we know that our key mitigation strategies, despite very long documents put out by the California Department of Health, we have 2 main mitigation strategies, and they are masking and distancing. Much less important are cleaning surfaces and reducing use of shared objects. COVID is not as much of a fomite disease, meaning we don't pass COVID on from, having wiped our noses and touched a doorknob and spread it to the next person who opens that door. That's the way that flu and other respiratory illnesses have been passed. And that's why we thought COVID would probably be a kid's disease or spread rapidly in schools. And it's turned out that COVID does not spread that way nearly as easily. So less attention to wiping down surfaces. That's not a likely area for people to get COVID. Less attention to, really focusing on how can we, not pass papers back and forth. That's really not much of an issue. Is masking, and keeping a distance of, the state has set a minimum of 4 feet for desks. When we see, and then on campuses, it's really important to remember that most likely when there are COVID transmissions on campuses, it's most likely to be adult to adult. So educators just need to be aware of that's, the highest risk is when adults are interacting with other adults. We have a lot of examples of failures that get, that are in the press and for us to read about. And there's a common theme. When something goes wrong, universally, it has been because masking has been inadequate. And there's also a common theme among the success stories from Europe and Asia, New York, North Carolina, Wisconsin, Mississippi, and here in Marin. The common theme of all of the success stories is universal mask use. So masks plus distancing is really on par with vaccines and blocking COVID transmission. Simple masks block about 70 to 80% of COVID transmission. I'll talk more about this because the CDC just updated mask guidelines today. But masks plus that 3 feet reduces transmissions above 90%, which is about what our vaccines are. And that's something that we all have in our toolkit right now. So the CDC update published today is recommending a cloth mask over the disposable mask, or tightening up the disposable mask by tying knots in the ear loops and tucking in the sides. And they did, and this is just sort of shows a picture of it. So why do this? It's because in our disposable surgical masks or medical masks, you can get this gap here on the side if it doesn't fit well. Putting a cloth mask over that just makes it more, it makes the fit better. Or you can tie a knot here. I have to say that this is not data driven. This is just my personal experiment with trying to knot these. I feel like that's not as easy as it looks. But wearing a cloth mask on top of the medical surgical mask actually increases the effectiveness of blocking COVID transmission from this baseline of 70 to 80% up to 96%. And this was just based on the simulation studies they did in the labs at the CDC with mannequins. So they found, a coughing mannequin and a non-coughing mannequin, both masked the traditional way with just a simple face mask, blocked 84% of the droplets. And that increased to 96% blockage when they put a cloth mask on top of the disposable mask. And that's on par with N95s. That's the effectiveness of preventing COVID transmission for N95 use, which is great news because this is pretty easy to do. So what is our ultimate measure of success in knowing that we have really, that we don't have COVID transmission going on in schools? That is the number of school-based transmissions. So when we have testing going on in schools, because all schools should operate with symptom trackers, meaning somebody needs to be doing screening that the students and the teachers don't have cough or fever or headaches or anything that could be a COVID symptom and coming onto campus. So you have a positive symptom screen, you don't go to school and you get a test and it's positive. Those are sort of, that's a bonus for the community. Those are people who are associated with schools, didn't give it to anybody in the school, but were screened and tested because they're associated with schools. And then those cases are picked up earlier. and people quarantine earlier, and there's less COVID spread in our communities. So those are a bonus to our communities. The disadvantage, or the price to be paid for opening schools, is how much school-based transmission is there. So we all know there's lots of benefits from in-person education. What is the downside? The downside is how many new COVID cases are we going to have because we've opened schools? So that's what school-based transmissions are. Marin County has probably the best website in the state, maybe in the country, in really documenting this. So in Marin, they use in their denominator here student days, and that means the number of people who are back on campuses, back at school, students and teachers, multiplied by the number of days they've been back since September. And that tells you how much exposure there's been overall. So it takes into account, if kids aren't there every day, et cetera. So it's a more accurate assessment of whether COVID is being spread in schools. So they have 990,000 student days so far, just about 1 million. And during that time, there have been 0 student to teacher transmissions. And that's incredibly reassuring data. I mean, 1 million days of people on campus, essentially. I mean, it's all the people on campus multiplied by the number of days they've been there. That's their denominator. In their numerator, how many COVID infections have there been that transpired on campus? And there's been 10 total. 0 student to teacher, 2 teacher to student. And this is majority just demographically, because that's what Marin County looks like. These are majority middle schoolers, although there are 5 high schools that are open as well. And 5 more high schools are slated to open next week. We also have data from the best study, just because it's so dang large, is from North Carolina. And this was published in the journal Pediatrics in January. It's from researchers at Duke University. And it's so important because they followed 100,000 people. I don't think there'll ever be a bigger or higher quality study than this. So 90,000 students, K through 12, were followed across public schools in North Carolina. 90,000 students, 10,000 teachers. And they were followed for a 3-month period from September to November, when community rates of COVID were up to 4 times higher than our purple tier. Beyond 29 daily cases per 100,000 population. And during those 13 weeks of the study, there were just 32 campus-based, school-based transmissions. If you had just looked at community prevalence, there are very, very high rates of COVID in the community. If schools were just the same as the community at large, it would have predicted 900 infections, and yet there were only 32. There were 0 student to teacher transmissions, again, and they found that middle schools and high schools were not higher risk than K through 6. In fact, there were 3 outbreaks in this study, and an outbreak in North Carolina is defined as a cluster of 5 cases in a school. Here we define it as 3, but 5 cases. And so of those 3 outbreaks, they were all concentrated in either pre-K kids, because they had initially decided that pre-K kids were too young to mask, and they changed that, and special needs kids who had a lot of difficulty with masking. But there were no outbreaks in the high school age group, which is great news, because I know that everybody's particularly worried about high school students going from class to class, and they did not show higher transmission rates. And how did they do this? They did it based on a very simple, effective strategy that they called the 3 W's. And the 3 W's were: wear your mask, watch your distance, wash your hands. And, talking to the researchers who conducted this study, it was really mask, mask, mask. That is the intervention that they were all concerned about. And they reported really high mask compliance, well more than 90% of people wearing masks correctly at all times. And I can get into in the Q&A about how they got to that level. But it was really sort of a laser focus on masking and managed to keep schools operating in person incredibly safe when COVID rates were very, very high in the surrounding communities. And these were, I should also say, public schools, no new investments in new HVAC systems or HEPA filters. They served Black and brown kids predominantly, they just looked like North Carolina, but 48% non-Latinx white and 52% of people of color. And then we have another smaller data set, but it's something else that was recently published on the CDC's website from Wisconsin. And these are rural schools and primarily serving white kids in Wisconsin. That's what Wisconsin tends to look like. K through 12, when community rates were very high again. So with positivity rates were actually up to 40%, which is incredibly high. They followed just about 5,000 students and 600 teachers for 3 months. And their intervention there was just, they got a grant to purchase extra masks to make sure everyone was masked. But it was, again, a focus on masking, not new, ventilation systems or capital investments, but really looking at masking. And class sizes were up to 20. And this was a mix of public and private schools. But they, again, had 0 student to teacher transmissions. They only had 7 transmissions overall from this, 5,600 roughly people that they followed over 3 months when community rates were very, very high. So just 7 cases of school-based transmission of COVID, and only 2 of those were in middle school to high school age group, mainly in the younger kids as well, but a really low number. And this graph is just to show that the community rate, which is here, the solid black line, doesn't predict school transmission, which is this dotted blue line down here. So community rates can be very, very high, and schools can be operated safely because they're supervised when there's universal masking. And that's really the theme of this slide too. So community prevalence is not an independent predictor of spread when there is masking. And the strongest predictor, the strongest determinant of whether you're going to have cases of COVID transmission in your schools is how well you're doing with your masking. So not how much there is in your community, but how good are you at assuring that everybody is masked? And this is in line of, this is exactly what we do in the hospital. We've been, taking care of COVID patients for a year now, and school campuses will never see the same number of COVID students or students who are positive for COVID that we will see in the hospital, where we see people every day. And the reason we haven't gotten COVID is because we mask and we enforce it. And then finally, so what does predict COVID in kids? So this is data from Mississippi from September to November. And they took a group of kids who had just tested positive for COVID, and they did case controls and compared them to similar kids from similar backgrounds who had not tested positive for COVID, who were negative. And then they went back to look, what exposures had those kids had who tested positive, and what predicted whether they were going to test positive or not? And the factors in those kids' background that were associated with a COVID positive test, with having COVID, were recent play dates in the last 14 days, having attended a social gathering, or reporting having had visitors in their home. Exposures that were associated with a negative COVID test, not having COVID, were actually having attended school or childcare where masking was enforced. So the lesson there is that social gatherings, not schools, are where COVID transmissions occur. And this is why we see huge surges around the holidays. And, schools are closed then. It's definitely not because of schools, although a lot of our schools are closed across the country anyway, but it's because people gather indoors, and they gather indoors and they sit close to one another, and they take off their masks to eat and drink and socialize. And that's quite different from the school environment, where we are requiring that students are spaced at least 4 feet apart and that everyone is masked. And then when it's lunchtime or any time that masks come off, it's really closely supervised. That's not what a social gathering looks like. And that's why we see these really low rates in schools and really high rates at the time of holidays and when people get together to be social. So we also have an expert panel, a council made up of researchers from Harvard and Brown and Tufts and Boston University that has been issuing guidance for school reopening and school safety. And they updated their guidance in December in the middle of our winter surge. And they said, we previously recommended that schools be closed once the average daily case rate rose above 25 cases per 100,000 people at the county level. Since July, our scientific understanding of COVID has increased significantly, as has our understanding of degrees of risk in schools. We can now recommend that schools be open even at the very high levels of spread that we are now seeing, provided that they strictly implement strategies of infection control. So they issued this statement right in the, sort of the height of this last surge, because they were seeing this data of schools were operating very, very safely, despite very high levels of COVID in communities. And we're actually seeing data that schools open was protective for kids and teachers, protective for the people who were attending schools where masking was enforced. And then the council's recommendation on distancing is actually less strict than California. So in the new California guidelines, the minimum number of feet between desks is supposed to be 4 feet. The analysis, and this is consistent with the World Health Organization and what most of Europe does, which is a meter, so over 3 feet. But their recommendation is 3 feet distancing for young learners at all levels of community spread, 3 feet distancing for high school students when the case rate is below 100 per day per 100,000, and increasing the distancing to 6 feet for high school students only when levels of community spread rise above 100. And that's, just an extra safety net, because helping with contact tracing, because high school students are going from class to class and, not cohorting at all. So what about, what about ventilation? So the most important thing is to teach with doors open. And if there's windows, certainly having the windows cracked is great and adds an extra buffer of protection. But opening the doors is really key. And it can be to an internal hallway in the school. It doesn't have to be, to the outside. It's just increasing the airflow so that you don't have this hermetically sealed classroom where people are there for an hour or longer and, sort of rebreathing the air. So as long as a door is open and there's some circulation of, there's some movement of air, that is the risk reduction that you need. And then, we know that eating is the most dangerous time because masks are our number one protection, and masks are not on when people are eating. So when possible, eating outside is great and should be done. It's not a requirement. It wasn't done in these studies that showed, really low levels of school transmission, but it's also something that is, we just know masks, it's all about masking. So when masks come off, try to make that time as safe as possible. One of the things they did in North Carolina is they prepped their students for eating. So it was okay, they didn't do it outside, like I said, but making sure people are distanced. And then they had their prep time where their, kids were opening their milk cartons and pulling out their food and everything with their masks on. And then having, the lunchtime monitor or the teacher or whomever it is, the supervising adult say, okay, you have, 20 minutes to eat. You have 20 minutes of maskless time and that's it. And then making sure that kids, stayed apart during that time. So really doing everything they can to minimize the risk when the masks come off. HVAC systems and HEPA filters are always, I think, an area of concern because it seems like, well, that means schools that have more resources are going to be safer than schools that have less. And it doesn't really turn out that way. And it doesn't turn out that way because although airborne transmission is possible, this is primarily a droplet disease. And there's a lot of confusion around droplet and airborne. So we know that COVID gets into the air. That's not, that's not debatable. But when we make this distinction between droplet and airborne, it just means how long can COVID hang out in the air? So if it's a droplet disease, primarily spread through droplets, then your little viral particles are attached to a water molecule from, as you breathe out moisture. And those are much heavier droplets, and so they fall to the ground quickly. Airborne is when you have basically viral particles on a piece of dust that's much lighter. There's no more water molecules, no more saliva essentially attached to that. So airborne particles stay in the air for longer. And that's a very small part of COVID transmission. In fact, so small that we actually don't see differences in transmission when you put in a new HVAC system versus when you don't. The benefit, the differences really come with masking. Masking is what prevents droplet transmission. HVAC systems reduce airborne transmission. And airborne transmission is a really small part of this. If somebody's sitting next to you coughing, you can have the best HVAC system in the world, and that's not really going to reduce the transmission. Those droplets, if somebody's unmasked, are going to go from me to you, and that's done. An HVAC system doesn't really stop that. Masking is what stops that. So another question is, why reopen now when vaccines are on the horizon? I address that a little bit because masks and distancing really bring a similar level of protection to vaccines. So we have that right now in our toolkit for operating schools safely, and all the, the data from North Carolina and Wisconsin, that's all in the absence of vaccines clearly from last fall. So we have very strong evidence of safety. And we also have, unfortunately, really strong evidence of harm from continued social isolation from school closures. And that's primarily in our adolescents, in our middle schoolers and our high schoolers. There's also, worsening academic slide that's a big problem and has a lifelong impact for older students. And that's, despite the heroic efforts of educators. This has been such a trying time, and it's just a really, really hard task, I think, to, engage everyone in the same high quality education through a computer screen. And then I just have a few slides on what we're seeing in the emergency department among kids. So an increasing number of children requiring emergency mental health services. This is from the Children's Hospital of Oakland. The red line is 2020, and the gray line below is 2019. And the difference between those two lines is the increase we saw last year. The mental health crisis is really broad. We've seen a doubling in the number of hospitalized kids who require mental health services. And the mental health crisis is severe. We have seen a 75% increase in children requiring immediate hospitalization when they're brought in by their families for mental health services. In 2019, just under a third of kids who were brought in could go home with emergency plans. Their distress was not so severe that they needed to be immediately hospitalized. And in 2020, over half of the kids brought in for mental health services required immediate hospitalization. And then we've seen a 130% increase in the number of kids requiring hospitalization for eating disorders, and an increasing number of suicidal adolescents in the emergency department. And sadly, in January, just this past month at the Mission Bay Emergency Department for Kids, we saw the highest number of suicidal kids ever on record. So the return to in-person education meets the social and emotional needs of teachers too, surprisingly, even though I know teachers who have not been back in-person schooling, many of you are probably really scared and nervous about going back. And I say that because it's really what we went through as healthcare workers at the beginning of this pandemic. And, and some people say, well, I didn't sign up for this. I mean, I don't think that really any of us signed up for this. It was really scary for us too. And, as an emergency physician, I am, a little more accustomed, I think, to putting myself in harm's way. But healthcare workers also include, we have pharmacists and clerical staff and environmental service people, and everyone has, who's associated with a hospital where we treat COVID patients has gone back or has been back, has never left work. And it was hard. It was scary. I can't deny that. But once you go back, the fear really melts away or dissipates for a lot of people. I think fear is at its highest right before the return, thinking, oh my gosh, this is, a death march. My exposures are going to be horrible. This is such high risk, and fears really get amplified. And then you get back into your routine, and seeing other people and seeing your students will be wonderful. And the risks are actually low, and we have the data to show that. And so I think the social and emotional needs of teachers will really be met and enhanced by return to in-person schooling. I know that might sound totally crazy, but in the little bit of data that we have from teachers who have returned, that seems to be the common reaction, which mirrors what we've seen in healthcare as well. Being, really scared early on, and then really kind of adopting, we can do this, it's okay. And then just a quote from a teacher recently who said, I was ready to give up on teaching until I went back to the classroom and saw my students' faces. And I realized there is no way I would give this up. And that seems to be a pretty common sentiment among teachers who've recently returned to in-person teaching. What about medically fragile family members in the intergenerational household? And this comes up a lot. This comes up for us too in healthcare. Are we putting, we might assume risks for ourselves, but what about, I live with my 80-year-old mom, or my sister has breast cancer and is getting chemo. I'm not, I can't just throw my family under the bus. So there are different ways that people decide to deal with that. Universal masking has really kept us safe. We have, many people, say in just my little emergency department, 150 people who work there. There are many of us who have medically fragile family members, and people deal with it, differently. But the main thing is that, do people decide to, wear masks or stay distant from family members at home? And most people have not. The masks, when you're out and about in the area of exposure, in the classroom, in the hospital, is your barrier of protection. So when you come home, you don't need to think, I've got to wear my mask. I'm going to infect my family members if I don't. The masking data is really, really strong. So that's not necessary. That being said, for people who have a higher risk for anything that goes wrong, like living with somebody who's medically fragile, I think the best solution to that is to do the double masking, to assume that healthcare level of protection and wear your disposable mask with your cloth mask on top of it, and realize that, you could treat a sick COVID patient with that combo. That's essentially an N95, and it's a little less comfortable, but it will give you that extra peace of mind that you have, very close to zero chance of bringing COVID infection back home. And then finally, I'm getting close to the end here. What about the new UK variant? I'm talking about the UK variant because it's the one that's most likely to become dominant in the Bay Area, although things always change. So it helps to know what's called the secondary attack rate. And the secondary attack rate is how likely am I to get COVID if I'm sitting next to someone less than 6 feet apart for more than 15 minutes and where one of us isn't masked. And so how likely am I to get COVID in that situation? In our regular old COVID that we have now, about 11% likelihood of getting COVID. With the UK variant, it goes up to what's estimated to be 14.7%. So it's an absolute increase of 3.7, but is a relative increase, it's greater than 30%. And that's what, and that's often what you see reported in the press. But I think it's helpful to keep in mind that although the relative increase is large, we're still talking about, I have in an unmasked, unprotected situation, just over a 10% chance of getting COVID if I'm exposed, and that goes up to 15%. So there aren't, on a population level, that means a lot more cases. But when you're talking about your individual risk in your classroom, I think it's reassuring to know what those numbers are. I think most people think they're much sort of worse than they are. And then for kids ages 0 to 9, the increase in the secondary attack rate went from 6% with our current form of COVID to 9% with the UK variant. Kids are just, less susceptible. And then ages 10 to 19, closer to adults, but still less than adults, the secondary attack rate went from the baseline of 10% for our COVID now to 12% with the UK variant. And this just shows, this is updated from the CDC yesterday, how many cases. This B117 is the UK variant, and we currently have 156 cases in California. No cases of the Brazilian or the South African variants yet. And, things are unpredictable, but it's most likely, according to our best scientists, that the UK variant is the one that will become dominant here over time. And I know a lot of you might have questions about the vaccines because there's a lot in the press about this, but the vaccines still work really, really well, even against the UK variant. So we have, currently approved in the US just Pfizer and Moderna, and Johnson & Johnson, it will probably be approved in a couple of weeks or on February 26th, we think. But for the Pfizer and Moderna vaccines, they're more than 90%, about 95% effective in blocking COVID. And they're basically the same with the UK variant. And with the South African variant, Moderna is maybe a little bit less, but still incredibly high. So, and as in a regular flu shot, we get, about 60% protection. And we all get our flu shots, or hopefully we do. It's really important to get your flu shots. The vaccines have been much more effective than we hoped they would be, last summer. So they're still holding up. They're still holding up quite well. And I think that might be, okay, I'm going to stop my share. Oh, gosh. I'm sorry, I've got funny lights coming in. Okay.
Dr. Noble, I'm going to summarize the most popular question, which is about masking. And how would you work with populations that cannot mask due to special needs, any other, physical issue that would prevent them from masking? How would you handle that in the classroom? How would you handle those students that cannot mask and cannot socially distance? And then questions about the type of mask that should be used, cloth or paper, and if teachers or students or both should be double masking.
Okay, those are great questions. So starting with the special needs kids first. So although I said the piece about, HVAC systems and HEPA filters, when we were talking about special needs kids in the North Carolina studies who couldn't mask, one of the things they did is try to bring, sort of small portable HEPA filters into those rooms with special ed kids. It's not clear how much of a role that played, but they added face shields as well. And face shields is probably a really good way to go. So in that situation, the teacher is much more like the healthcare provider. So as a healthcare provider, I'm actually not considered exposed to somebody and need like contact tracing and testing or whatever, unless I have been near a patient for, less than 6 feet, more than 15 minutes, and one of the two of us isn't masked and the patient is COVID positive. Otherwise, we don't do any contact tracing at all. Like I take care of COVID positive people every day. And as long as they're masked and I'm masked, we consider it no risk. It's interesting that when the school regulations were written, you have to contact trace everybody who's in contact with each other, even if they were both masked, which is really conservative. So all that is to say, like when I treat patients who can't be masked because they are sick and they're breathing heavily and they need breathing treatments and or they can't tolerate masks, it becomes, I need to be more protected, and my extra protection is an N95 in that case. For teachers who are teaching kids who cannot be masked, double masking for sure, which gets you to the level of an N95, or even, you can purchase N95s that are, probably more efficacious than, they're very close to what we're using in the healthcare setting. You can purchase those pretty cheaply on Amazon at this point. But double masking is similar to that. And so I would recommend double masking and a face shield if you are working with special needs students who are not masked, because having both of you masked is what's really important. And the distancing is, when we talk about distancing, the best data is really for 3 feet, but the California guidelines are 4 feet. So that's what everybody needs to try to achieve. That's an extra foot of buffer, probably beyond what the data really supports. But that distance is for, if you can't keep that 4 feet of distance, it's if you can't keep it for over 15 minutes that we really think the risk is increased enough where you would say, okay, if a student tests positive, you need to get a test and quarantine and do contact tracing. It's only if that close exposure, that less than 4 feet, has gone on for more than 15 minutes. So teachers don't need to be afraid of, handing back papers and being face-to-face with a student as they do that, or going around and proctoring an exam. It's not, COVID is very infectious, but it's not infectious like that. Walking by somebody, brief interactions, redirecting a child who's doing an exam, that is all fine. It's really the sitting close next to somebody for more than 15 minutes where we really see the increased rate of transmission, where you start to get to that, that 10% and maybe what will be 15% attack rate. And then in terms of double masking, that, the CDC finally came out with guidance today, which hopefully is a new sign of how actively the new government is going to be engaged in helping us battle COVID, as opposed to the last 4 years. But the double masks brings that level of protection from, basically 80% to over 90%. So I think it makes total sense for people to do it. And underneath, though, the important part of those slides is that the mask next to you needs to be the medical mask or the surgical mask, the disposable mask, the paper one. And that probably has the highest level of filtration. But the reason that can be less effective is if you have gaps on the side and it's not as snug. So your cloth mask that you put on top is just to improve the fit, to make it fit more snugly. So the disposable mask, better filter, you don't want to put that on top. You want to have that next to your face, but you want the snugger fit by either tying the knots or putting the cloth mask on top of that. I hope I answered most of those questions.
What about a teacher that can't wear a mask?
Yeah, that's tough. Masks are really, really what stops COVID transmission. So if a teacher cannot be masked, I think that medical accommodations might be more of what you're looking at. It's not, it's, yeah, the mask is really our number one way to block this transmission. So somebody who is unmasked is going to be at considerably higher risk.
Okay, and for teachers that have underlying health conditions that put them at higher risk of severe illness, are the guidelines for reopening enough to protect them? And if not, what additional mitigation or other strategies are needed to protect these people with underlying health conditions?
Yeah, so the data that we have on safety is all comers. It's not, it's not a select group of, teachers between the ages of 30 and 35 who had no, pre-existing health conditions. I mean, that's all comers. And so in the fact that we saw in these 100,000 people in the schools in North Carolina, 0 student to teacher transmissions is incredibly reassuring for everyone. I would repeat that I think double masking is a really great way to improve, get that 80% protection up to closer to 95% protection. And that's the level of protection we have when we take care of sick COVID patients. So it should be way more than you need in the classroom setting where you shouldn't have anybody who's sick on campus. I mean, your first, the very first thing is a symptom check. The kids who are coughing and who are sick should be, nope, go home, get a test, follow all that out. So the only people who are COVID positive who make it onto campus are asymptomatic, those who don't have symptoms and are just carrying COVID and we don't know it. They are lower risk for sure. They're a lot lower risk than somebody who's sick with COVID and coughing. And so the double masking is essentially providing the level of protection of an N95. And we know an N95 protects us from the sickest COVID patients. So it's much more than is needed in the school setting where the worst case scenario is that your students or your colleagues have asymptomatic carriers of COVID. So it's a long way of saying that masking provides great protection for everyone.
Great. A few questions about the North Carolina study that you shared. Do you happen to know the class sizes of those schools and how many students on average were in the classes?
That's a great question. So as opposed to Wisconsin, which had a upper limit of 20, North Carolina had an upper limit of 16. So it's not, it's the common feature in a lot of these studies is really the masking and not the number of kids in the classroom, but they had, 16, which is smaller. They did have a lot of high school students in there, and they did go from classroom to classroom. So it wasn't cohorting. But they did limit their class size to 16 and 20 in Wisconsin. So we don't have study data that says, what about 30 kids in a classroom? But there's not reason to think from what we know from these different studies with different numbers of kids in the classroom, that the number of kids in the classroom is what's key. The common variable for all of these is how good you are with masking.
Great. And a follow-up to the North Carolina data. North Carolina has a very different population than those that are here on the central coast of California. Many of our students are living with multiple families in a single home, and their parents are essential workers, often in the ag industry. Will this affect us differently because of the different types of populations that might be in our schools?
That's a great question. And and I think it comes up a lot. In the North Carolina data, the reason that it is so helpful is because of the population, the really diverse populations that were represented. So it was somewhere around a third of kids who were Latinx, and around 25% were African American, and 48% were white, non-Hispanic. But the demographics of North Carolina contained a majority of students who had the same risk profile of our most at-risk families in California, which is why it is so helpful for us. So lots and lots of intergenerational households were represented among that student population. Fair numbers of agricultural workers, people who were definitely at risk of COVID. So it's quite reassuring in that sense. And then I've heard people say on the other side, but then what does that mean? Does that mean if we don't look like North Carolina, if we're, talking about a different population? And then the Wisconsin data is different from that. So, North Carolina was much more diverse and had, more urban school districts in it. And then the Wisconsin data was primarily white and rural. And we saw very similar, really, really low levels of transmission in both of those settings.
Next, popular question, several questions about symptoms. What common symptoms have you seen with students, especially students kindergarten through 8th grade? We send home students for headaches, sore throat, but might not know the difference with allergy season coming up. How do we tell the difference between what's an allergy versus what's a cold versus what's COVID? Do we keep everyone with all symptoms home? And how will we be able to tell if a student has taken a fever reducing medicine and therefore isn't showing a fever?
Yeah, so those are really great questions. I think that the most important thing is to, sort of the school door, the gatekeeper for kids coming in is to be conservative. And we have, kids who have what sounds like allergy symptoms, but they've got a runny nose, or if they get a headache with their allergies, they need to have at least one basically doctor's note saying, no, this is consistent with allergies. You don't have to worry about COVID. It should not be, students, schools should not be taking on that burden. You can get, in a lot of places where it is open, where kids have gone back to school and they've sort of greased the wheels and all of this. Physicians, pediatricians have, written very explicit sort of notes that go with the kid. Like, these are the symptoms that Johnny always has that are, really allergy, don't worry about them, but this is the tight list. And if there's something new, send Johnny back to the doctor. So the first time that happens with anyone, you should not be, saying, if they tell you it's allergies, that's great, but your doctor needs to tell me it's allergies. And I would have a very low threshold for turning a kid back until they have more evidence, from their doctor. And if their doctor is not sure, then their doctor will order a COVID test, and that will put bring clarity to the situation. Fever reducing medications are, I think that's been an issue in childcare for a long time. Your kid can't come back if they have a fever and their parents give them ibuprofen or Tylenol or whatever. I don't know that there's a great way to prevent that, but fever is not the most common sign in kids. In fact, I should have kept in a slide. I can add to it. It's, I don't think there's a super clear way around that, but that's not the number one sign in children anyway. And something to keep in mind is one of the things that the attitude in North Carolina, which might sound really counterintuitive, but the attitude of, those schools all being open when COVID rates were so high was that we are going to act like everybody here has COVID, which is what we do in the hospital. You mask and you distance, and that's just it. That's the way we're living until we're through this thing. So you have, when you talk about symptomatic COVID patients or people with COVID being more infectious, it's primarily because they're coughing and their respiratory droplets go a farther distance. So a kid who has, taken Tylenol and had a fever, and that fever is because of COVID, and now they seem fine and they go undetected and they're masked, that child is still going to represent an incredibly low risk to anyone in the school. They're not, they're not likely to be any kind of super spreader because they're not coughing and they're not spraying out their respiratory droplets. So hopefully there won't be, a ton of cheating there, but it won't sink your ship either. It's not, masking is really what protects, not the amount of COVID that's in the community. And in, in North Carolina, there had to be COVID positive students who were on campus. I mean, with rates that high, it just happens, but it doesn't spread because people are masking and distancing.
Few questions about the vaccines. Can you talk about if all of the vaccines that are available right now are approved by the FDA? And what is your opinion on older teachers or teachers with pre-existing health conditions waiting until they are vaccinated to return to the classroom? Is that something that is medically recommended?
Yeah. So the vaccines are all given at this stage in sort of what's been done in the COVID pandemic emergency use authorization. And so, but the only two that we have that FDA approval for are Pfizer and Moderna. But we think the Johnson & Johnson vaccine will be approved later this month. And then hopefully after that, we'll get a few more, and then they'll really help with our allocation and the number of people we can get vaccinated quickly. Right now we are limited by the sheer number of doses that we have, more than just the logistics of how to get those doses to people. In terms of waiting to be vaccinated, it's an individual decision that I think, teachers and staff should discuss with their regular doctors. It's not medically required. And, and that again is because we have all of this data from our pre-vaccination era. I mean, we've only just, started to vaccinate. So there's not, when you look at these large swaths of population in public schools and having teachers of all ages and all sorts of different health backgrounds, and you have 0 cases of student to teacher transmission, that's just, any way you slice it, it's really, really safe. And that being said, everybody has their own sort of risk aversion or tolerance. And I think speaking to, your individual doctor is always a good idea.
Okay, back to the 4-foot distance question. People are asking about the data that you are using or referring to for that 4 feet or 3 feet. We know that the 4 feet is the requirement from CDPH, but what sort of data can you share with us about distancing? And then what do you think about desk guards, plastic guards or shields for students and teachers?
Yeah, so the distancing data comes from how, most of it got started by doing work in labs and how far droplets, how far droplets could go and how the majority of them, how quickly they fall. And so that's where sort of the 6 feet came from. And then looking at the actual, implementation, like when people get COVID and when they don't, their 6 feet does not seem to be required, meaning that you have a lot of data from kids who have gone back to school, a lot of predating the North Carolina data. So kids in European countries and in Asian countries that weren't really doing social distancing beyond the meter. So just over 3.3 feet. And so we can't say, as opposed to masking, where we put something over our nose and mouth, and we were really good at measuring the filtration, what can escape through that mask, and for the recipient, what is the mask blocking from coming in. That's a pretty easy thing to measure. The impact of social distancing is a little harder because nobody's doing that without masking. So it's assumed that it is an important part of this. And I think it is, because we know that most droplets fall pretty quickly. But I think time will tell how much of that distancing we really need to maintain. But what we know from observations is that, in pretty much every country outside of the United States where kids have gone back, they've used a meter, and they're masking. When they have outbreaks, it's because they haven't masked. In fact, in France for most of the pandemic, they sent COVID positive kids to school because knowing they were COVID positive, but thinking kids don't spread it that easily and they don't get particularly sick. So, and it's only been recently that many European countries have actually even enforced the masking. And all they really did was the distancing of a meter. So we know that a meter is helpful because it's, it's worked when you weren't doing much else. But in the masked environment, when masking is really the superior thing, we can't say exactly how many feet. 6 feet, sure, that's great, but it's really hard to run a classroom in 6 feet. And whether it's necessary or not becomes a really important question. 6 feet is not, and pretty much nobody has done 6 feet who's gone back to school. And so we've rolled it back, and CDPH has rolled it back to be closer in line with the data we have from Europe, where people were going to school with really iffy masking and still weren't getting infected, and they were using a meter. So that's really where the 4 feet comes from. In the future, I think that distance might be reduced further, but 4 feet is, hopefully not a huge barrier for most schools. And in universal masking is, seems more than adequate, because we know that 1 meter of distancing when masking is not that great has done enough to block most COVID transmission. So the two together are super effective.
Thank you so much. That's so helpful. How often were students and teachers and any other staff tested in the studies that you are referring to? And what can you share about testing cadences?
Yeah, so in most of these places, there wasn't asymptomatic screening. So there's different ways to test. So if anybody gets ill, they need a test, and then you go back and test the people in the contact tracing, who they associated with, or anybody who were less than 6 feet for more than 15 minutes. In the North Carolina study, it was quite an elaborate process where anybody who displayed any signs of COVID affiliated with the school, or family members affiliated with students at the school, got tested. And those transmissions were adjudicated, or that the local health department took charge to say whether, in collaboration with the schools, but it was all, they had basically like a committee to make sure this was completely transparent, because if there was any suggestion that positive cases were being swept under the rug, the whole point of the research would be lost. So they had a pretty elaborate process that involved the local public health departments to determine whether anytime there was a positive test, was it associated, did it happen on the school grounds? And it was pretty sophisticated and rigorous, but not just asymptomatic screens. And that's, they probably would have found more people who were positive if they just did asymptomatic testing, because there's so much COVID in the community. But again, the question is really, is there spread on campus? Because that's the price we pay for opening our schools, not whether there are teachers and students who don't know they have COVID and they get tested. And because the school is open and they turn out to be positive, that's not, that's not the school's fault. That's not that helps the community, but that's not a cost to be paid. So asymptomatic testing. So we always need robust testing, ready access to testing whenever you have somebody who is symptomatic. And that's, and the turnaround time for the test is really important. So if you go to get tested and you can't get your result for 5 or 6 days, then you're going to have all of that lost time where you're quarantined and you don't even know if you're COVID positive, and it's hugely disruptive, and it's really problematic. So having ready access to testing for anyone who's symptomatic with a rapid turnaround time is really important. And then the other question of just asymptomatic screens is, An interesting one, early in this pandemic, I was a bigger advocate for doing a lot of asymptomatic testing because I thought that would be maybe a way to reassure everyone that, hey, we can do this safely, it's okay. And the response that I've got from schools, in this case, I mean, more the schools that are open are private schools versus public schools. But even pretty well-resourced private schools have found like testing is really kind of a big pain. You have to, I mean, if you're doing universal testing every week, say, for all of your students and all of your teachers, it's an awful lot of results to keep track of. And if you don't have a really high community prevalence, you're likely to have your number of true positives and false positives be very similar. And what do I mean by that? So there's something called specificity of a test. And that means if I don't have the disease, if I don't have COVID and I get a COVID test, how likely am I to get a negative result? And that's the specificity. And so most of the tests are about 98, 99% specific, which means that every 1 or 2 people out of 100 who don't have COVID are going to get a positive test and think they have COVID when they get a test. So if you start doing universal asymptomatic screening, like I don't have any symptoms, but we're going to test everybody every week, you're going to get a lot of false positives. That's just the nature of the test. And you create a lot of anxiety and it's a lot of work. So the role for asymptomatic testing is really when prevalence rates are very, very high. Because when the rates are high, the likelihood of a positive test being a true positive is just higher. So if you are testing in a population where everybody has COVID, you can just do a flip of a coin and say, oh, that's that whatever way that coin lands, that's a positive and that person has COVID, and you'll be right because everybody has COVID. Your test doesn't really have to do anything for you. If you are testing in a population where there's very, very little COVID, every time you get a positive, it's going to be more likely that it's a false positive than a true positive. I don't know if I explained that very well, but the bottom line is that doing asymptomatic testing universally for all of your teachers and students makes sense when you're going back in the height of a surge. And when your community prevalence is less, like say red tier, you're gonna contend with a lot of false positives.
That's so helpful. Thank you. I'm going to jump back to questions about masks. People are wondering if N95 masks are supposed to be exclusively for healthcare workers. What do you recommend for those in the classroom? A KN95, a double mask, and what sort of PPE recommendation would you have for staff that are performing toileting duties, G-tube feeding, things like that? Do you recommend gowns, gloves, face shields? Just a little bit more about the types of masks that would be available to educators.
Yeah, so the K95s, I think, are very, very similar to N95s, and those are widely available. And so I think anybody who is in higher risk, who is changing G-tubes, for instance, wearing a K95 or double masking is a really good idea. And then a face shield. So what we do, the changing G-tubes is starting to sound more like a healthcare setting. So what we do in the healthcare setting is we wear our N95 and we have a face shield and we wear gowns and gloves. It's, it's not as much of a contact disease as the flu is. And so some of the gowns and gloves is because we were assuming that it was going to be similar to the flu, and it's not. But if you're really doing, sort of almost medical type care, I think that that's a really good idea. It's not nearly as important as the masking again, but the masks, having a high quality mask, so double masking if you don't have an N95, and then having a face shield on top of that keeps your mask clean, and it'll block, big secretions that come out during that G-tube change. And it preserves your mask. We N95s, actually our supply of them is quite good now in California. I did, an N95 reuse study that's on the CDC website, and it was a small study, and we're doing another one now. I still reuse my N95. I feel like I'm like somebody who survived the Depression, and I don't want to throw away anything that I think could still, has a lot of use in it. So I traditionally reuse my N95 over and over, and a lot of us do, but it's no longer required because our supply is ample, and you can actually order N95s off the internet. So they're not, that's something that people can now do, and you're not stealing it from healthcare workers.
Great. And can you just address how often can a mask be reused? And should a disposable mask be used once and thrown away? Just your recommendations on masking. And that's a question from our YouTube channel. So anyone on YouTube, please continue to supply your questions through the survey link.
Yeah, the real time to throw away your mask is when it's visibly soiled or has gotten wet. And we think that, its ability to filter is just not as good when it's wet. And then if you reuse it too much, and the elastic becomes loose and you lose the tightness of your fit, that's the other thing to be concerned about. Reusing, I reuse the disposable surgical masks all the time, but it's simple. If you don't want to worry about the fit and inspecting it for wear and tear, and if it's dirty or whatever, using it one per day I think is a completely reasonable thing to do. They're pretty cheap, and hopefully we won't run into supply problems like we did at the beginning of the pandemic. But if push comes to shove and they become scarce again, the things that you're really looking for when you're deciding when it's time to change it is when it's wet, and then you need to swap it out, even if that one is not going in the garbage. And you need to make sure the fit is good. The new CDC recommendation for putting a cloth mask over the disposable mask really gets around the fit issue because it's holding it tight to your face. But that's one of the issues with reuse. It's just if the elastic gets worse and you create gaps, then you're compromising the mask's ability to protect you.
Great. A couple of final questions as we wrap up. We want to be respectful of your time. Thank you so much for sharing your expertise with us. About models of instruction, with the data that you're sharing, are these mostly hybrid models where students are attending for just a few hours a day or just a few days a week, or is this full in-person instruction? And what about teaching outdoors? Is that ideal or is it unnecessary?
Yeah, those are great questions. So the models were mixed in the largest data set in those 100,000 people in North Carolina, or the 90,000 students. So they didn't require a certain set schedule. So there was some variability in the number of hours each kid was at school. I think one of the really important findings that we have now, and that's alluded to in the Mississippi data, is the most dangerous time is not when kids are at school, it's when they're out of school. So we initially thought, in these A and B schedules and all of this, sort of rigmarole of how we could space out students, that part of the reason behind that was we were just going to decrease kids' exposure to others during the school week. That data has now been turned on its head. So kids are typically safer when they're at school than during their off-school hours because they're better supervised at school. They're more likely to be properly masked, and they're more likely to be distanced, which is why being in school, at schools that were enforcing masking in Mississippi, decreased the chances that you were going to test positive for COVID versus kids who went on play dates or social gatherings, et cetera. So the number of days a kid is in school a week does not need to be reduced as a COVID safety measure. In fact, it's probably the opposite. So the amount of COVID in your school is likely to be less if you have kids back 5 days a week. The issue becomes not everybody's going to come back, and we know that. Although once we sort of, get in the groove and do this, the number of families who don't want to send their kids back will probably decrease relatively rapidly, or that's been the case in other states that have opened. But the hybrid model, I think that the thing that breeds the highest level of teacher satisfaction, which is a huge, huge consideration, is the simultaneous teaching, if that can be pulled off. That has, the teaching groups and the educators that I have met with have really resisted and, legitimately complained about, if I'm going to teach the in-person kids in the morning and have to teach the remote kids in the afternoon, and I'm doubling my workday, that's not sustainable. But hybrid teaching, where you're simultaneously teaching kids who are remote and in the classroom at the same time, really seems to be the best way to go. 5 days a week being the safest in terms of minimizing the out of school exposures. And then what do you do for if you have more kids than you can fit in the classroom? And then are you forced into, schedules where a child can only come 2 or 3 or however many days a week because the classroom just is not big enough to accommodate the distancing. And that's an issue that I think really needs to be dealt with creatively to, keep our teachers all sane, is to, do everything we can so that we're not asking anybody to double teach, trying to have as close to a 5-day-a-week school schedule as we can possibly pull off, and every effort being made to creatively use spaces outside of the classroom, gymnasiums, libraries, any space that's available so that you can keep the kids spaced, the 4 feet, which they need to be, but getting the most normal schedule that you can, I think will keep teachers happy and keep families happy, and is really the goal. In terms of teaching outside, it's not necessary. I mean, the data that we have on safety is indoor teaching, but if you were going to use your outside space, I think the highest yield would be having eating done outside. So it's, you have really, really low levels of transmission in schools, period. But the highest risk time is when the masks come off. So if you're going to do anything outside, I would say do the eating outside, and that is the highest bang for your buck.
Great. And that leads us to our final question or group of questions about recess and outdoor play, shared playground equipment like playground balls and hula hoops, jump ropes. Should students be playing outdoors? Do they need to be masking while they're playing outdoors? And what about other activities where you can't mask, like arts classes, where students are singing, dancing, or playing instruments where they need to have their masks removed?
Yeah, I don't think we're ready to reintroduce activities where the masks come off. I mean, that is really our primary way to prevent spread. Outdoors, I wouldn't worry about kids on play equipment. I mean, it's really not, we don't have, like in the emergency department, for instance, we, print discharge paperwork from the printers, we share pens, we hand out paperwork to people. We don't worry about it. We have not had any transmissions where we think we've given COVID to somebody or somebody's given it to us from sharing, from passing papers and sharing pens, et cetera. So the same goes for playground equipment that people touch. And I know that in our last stay-at-home order, playgrounds were initially closed, which caused a great outroar among the medical community because it was not evidence-based, and that was removed. That was twofold. It was, the grouping up at playgrounds plus the touching of the equipment. But there's really no data that suggests that kids climbing on the same equipment, passing jump ropes back and forth, balls, is a risk. And even if you have, COVID that survives on a surface, if you're masking and the worst case scenario, which we don't have evidence for happening, but if you're, sharing a jump rope and somebody has COVID and their respiratory secretions get on that jump rope, and then you touch the jump rope, you're not going to get COVID through your hand. It's, putting your contaminated fingers into your nose and your mouth. And that's what the mask is for. And so one other thing that you can do is make sure that anytime somebody is, gonna touch their face or take off their mask for eating and drinking, that they wash their hands first or use hand sanitizer. But the playgrounds, I wouldn't worry about. I don't think that has not been shown to be a source of spread anywhere. In terms of kids masking outside, they should at this point in time. We shouldn't be getting kids together and taking off their masks, even though outside is 1/20th of the risk of inside. It's just such a big airspace. It's way safer. Which also means that you can be a little bit more liberal with the kids running around. You don't have to be as worried about their mixing because they're outside, and outside is just really safe. But they should keep their masks on. We're not ready, as far as I know, in the state regulations or elsewhere, to start letting kids do indoor bands or choir. There might be some regulations coming out about properly distanced outside with those activities, but taking off the masks inside for anything but supervised eating is probably not a great idea.
Great. Well, with that being our final question, Dr. Noble, I just want to thank you so very much for taking your time today to be with us and to share your expertise. We all care so deeply about our students, and we're wanting to ensure the safety of both our students and our staff. Our educators have to be safe and feel safe to be able to return to their classrooms, and basing these decisions on research and science is really what we need to do. And so we are so thankful for you being here with us today and sharing your knowledge. I want to remind all of our participants today that this recording will be available on the YouTube channel at the Santa Cruz County Office of Education. So please do know that you can access it there. And for the questions that we were not able to answer today, we're hoping that Dr. Noble, you might help us out and get us those answers in writing so that we'll be able to share all of those with all of today's participants as well.
Absolutely.
Great. Again, thank you so much. And we want everyone to have a wonderful rest of the evening. Stay safe, be well, and we'll continue to work together and learn together so that we can safely reopen our schools. Have a great evening.